Introduce the next speaker. This is Dr. Gamini Pathirana, who's a consultant neurologist at National Hospital of Sri Lanka, and he will be speaking to us on non-motor manifestations of Parkinson's disease. Over to you, Dr. Gamini Pathirana.
Thank you, Kishara, and sorry for not being able to be physically present there for unavoidable circumstances. And good morning to all of you, and I would like to thank CCP, the President, Council, and Kishara for inviting me, and I take it as a privilege to talk to you on this topic. I understand probably we are a little behind the time as well. What I'm planning to do within the next probably half an hour or so, 25 minutes, to talk to you on non-motor manifestations of Parkinson's disease. Well, Parkinson's disease has a visible entity, which is actually the motor component of it. And all of us know Parkinson's disease has tremor and rigidity and slowness and postural imbalance, dystonias, and all the movement problems, which you all of us see. The patient can see, the doctor can see, the family can see. But there's an unseen symptomatology behind Parkinson's disease. In fact, the unseen burden of symptoms actually is huge. If you look at the tip of the iceberg only, that we see the motor component, but behind unseen symptomatology is huge. And in fact, those are the ones probably making them suffering as well. A lot of symptomatology reducing the quality of life is coming from non-motor symptoms. And these non-motor symptoms are classified under a few headings. You see autonomic dysfunction, and these are actually the autonomic nerves getting affected. These are peripheral nerve system, and cognitive dysfunction under dementia, and then sleep disorders, mood disorders, and pain and sensory disorders, which also are common in Parkinson's patients. And then there are certain non-motor manifestations coming from the treatment that you give for Parkinson's patients, like, for example, impulse control disorders are actually due to dopamine agonists that are being given to these patients. And it took about 20 years for people to understand these impulse control disorders are coming from this particular treatment, but now we know it's coming from this particular dopamine agonist, so we can control them. And psychosis also can happen as a part of a pharmacotherapy, or it can happen due to the disease as well. And so there are non-motor symptoms coming from the disease itself and symptoms coming from the treatment. And we all knew Parkinson's disease is due to loss of dopaminergic neurons in the substantia nigra. We have all seen this picture on the right side, the autopsy specimen of the midbrain of Parkinson's disease showing less blackness in the substantia nigra, that is loss of dopaminergic nerves in that region. And we know that this happens because of deposition of alpha-synuclein, it's a protein particle within the nerves, and it will be shown as Lewy bodies. And you are seeing the two pathology specimens. This is what we knew. But a guy called Heiko Braak in 2003 put forward a different theory, saying what he did was he caught people who are dying from Parkinson's disease at various stages in their illness. People who are with early illness dying due to maybe other reasons, and people who are dying in the moderate degree of Parkinson's disease and severe degree of Parkinson's disease. And he dissected the brain and looked under the microscope for Lewy bodies. And he found that in early in the disease, you have these Lewy bodies distributed in the medulla oblongata and olfactory bulb, that region. And as the disease progresses, it progresses to the midbrain and then substantia nigra and the basal ganglia. And in the last stages, it spreads to the cortex as well. This staging is an accepted thing among the movement disorder popularity. And then, in fact, this progression tells that the clinical progression of the disease also. In the early phase, we have anosmia and constipation, the early phase, you have anosmia and constipation, and then you go on to develop the motor manifestations, and then you develop this advanced manifestations of Parkinson's disease with psychosis and dementia and so on. Not only that, we earlier knew that this is a disease due to dopamine as a neurotransmitter, but we know that there are other neurotransmitters also involved in this disease, bringing about symptoms. So now non-motor symptoms are explained by involvement of all these neurotransmitters, and they are helpful in treating them as well. And if you look at the progression of this disease, we understand that the red arrow indicates where the patient presents to the doctor, usually diagnosed at the stage of the motor symptoms. And when you ask from them whether they had any symptoms before this motor symptom, they always come out with this other symptoms, constipation, anosmia, and so on, had been there for number of, probably some of them are going backwards to 20 years or so. And then gradually these patients progress to advanced motor and palliative phase. But what we know when you look at this diagram is that non-motor symptoms spans throughout the disease. And we also know that non-motor symptoms starts before the motor symptoms comes, and also severity and the number of non-motor symptoms increases as the disease progresses with the duration of the disease. And we know that patients sometimes do not report these symptoms, and doctors fail to ask all of them. Maybe you will ask all of them, and family also might not detect certain things. So these symptoms are there, and it's not picked up, and they are suffering from these symptoms. So we need a checklist kind of thing to find out these symptoms. So there are established validated questionnaires available which are being used. These are some of the questionnaires that they use for picking up non-motor symptoms. There are two groups of questionnaires here. One of them, at the top here, you see they're looking at all the symptoms. And there are particular specific problem-related directed questionnaires also available. So depending on the circumstances, you can use them. How are you going to get this information? You can get the patient to fill when you're waiting in the consultation room, the waiting area, or the carer can do it. Or you can email it and then they fill it and send it back to you, or in certain places where you use mobile apps also to get this information to the doctor. So by the time you have the consultation, you have some understanding what are the symptom burden this patient is having. If you look at the non-motor symptoms secondary to pharmacotherapy, psychosis is one of them, which is seen in 1/3 of Parkinson's patients. And not all of them will report this to consultation. And most of them are having visual hallucinations, not much of auditory hallucinations. So they are not very scary for the patient. Sometimes you see crawling bugs, animals, and people, including children, but they are not talking, so they are not very scary for the patient. And can be caused by the disease, or can be caused by the medication that you give, or sometimes they are precipitated by infections and dehydration and so on. So when you treat, you have to treat the precipitant. And if you need an antipsychotic, you would probably choose quetiapine, clozapine, or pimavanserin. These are the drugs preferred because they do not do any damage to the extrapyramidal motor aspects. Clozapine seems to be a good alternative, but not very commonly used because of the demand for frequent hematological screening. And after treating, if you think a patient is still psychotic significantly and disturbing, maybe you might have to withdraw the medication that you are giving for Parkinson's disease. And when you are withdrawing, you have to withdraw in the reverse order. Anticholinergics are the most likely culprit. This is the first to come out on the list. And levodopa is the last to come out because that's the most effective treatment for motor manifestations. We take it out last. Impulse control disorders, which I mentioned before, was found later that this is related to dopamine agonist treatment. So what they have is compulsive behavior. They have pathological gambling, hypersexuality, and compulsive shopping, compulsive eating, and so on. Unless the family is aware, sometimes these things are missed, actually. And sometimes you can have a spectrum of it. So people can be having milder form of this. and this is linked to the treatment and seen in younger people and more common in men as well. I'm seeing some images which I'm not making. I'm not sure how it comes. These lines can't make it disappear also. I'm sorry for that. Non-motor symptoms cause more distress than motor syndrome, actually. Sometimes these non-motor symptoms are treated by doctors without understanding that they are Parkinson's disease related. They say a single patient may have up to about average about 9 symptoms, though all of them are not symptomatic. And this is a scan done on the heart. This is MIBG cardiac scintigraphy. The sympathetic nerves in the heart, actually these nerve fibers do not take up MIBG if the sympathetic fibers are lost. So on the right side, you see Parkinson's patient where sympathetic fibers are not there. On the left side, you see a normal person, indicating that deposition of alpha-synuclein, which is a primary pathology in Parkinson's disease, it does not only happen in the brain, it happens elsewhere also. This is a good example that the deposition of alpha-synuclein happening in the sympathetic fibers in the heart. And we also know that constipation that they have is because deposition of alpha-synuclein in the mesenteric plexus. So this deposition takes place elsewhere as well. In fact, now people think Parkinson's disease is a multi-system disease rather than a movement disorder, whether we need to reclassify this disease. Orthostatic hypotension is common, about 60%, and they lead to increased rate of falls and fractures, and can be asymptomatic in certain patients. You might wonder how it can be asymptomatic. The systolic blood pressure, when it falls below the level of cerebrovascular autoregulation, patients will be asymptomatic. And so orthostatic hypotension can occur from the disease itself or medications as well. So you need to find out what exactly is causing this. And you also know autonomic manifestations are dominant in this particular condition called multisystem atrophy. So you might have to differentiate these two as well. How you treat it? So it can also, it presents with postural dizziness, but some of them may not present with postural dizziness, but they will present with postural other symptoms like postural disturbance of vision, postural impaired thinking or headache, the coat hanger distribution. Coat hanger distribution is the neck and the bilateral shoulder, and postural pains. Sometimes when you get up, you have various symptoms. So they are all related to low blood pressure. How you treat? Of course, we all know how to treat hypotension. You increase the fluid and salt intake and compression stockings, elevate head under the bed, and physical method by abdominal binder and pressure stocking to reduce the pooling in the abdominal area or the calf. And also you can use certain pharmacotherapeutic agents to counteract this. And in the night when you sleep, normally what you expect is the blood pressure to drop, but in certain patients, because of this autonomic disturbances, you will have high blood pressure during sleeping time. So you have supine hypertension. Sometimes it can go to very dangerously high levels. So supine hypertension also is a problem in advanced Parkinson's disease, which can coexist with orthostatic hypotension, which is a very difficult thing to manage, because when you try to manage one end, the other end going to get exacerbated. So orthostatic hypotension and supine hypertension, when it exists together, it's very difficult to manage. But then there are various ways of counteracting it. Maybe you have to pay attention to the more dominant one. And sometimes these patients do not go into the lying down position. They are propped up during the sleeping hours. And hypotensive drugs may be used at night, and hypertensive drugs may be used in the morning. So there are various ways of handling it. Gastroparesis is common in Parkinson's patients. This also, again, because of the bradykinesia in the bowel. So the mesenteric plexus and the nerves are affected. So there's reduced motility. So food gets stuck in the stomach. So this causes symptoms, reduced appetite, early satiety, heartburn, and sometimes leads to weight loss, because when the stomach is full, they don't eat. And when the drugs get stuck in the stomach, the syndopa or the levodopa gets stuck in the stomach, there will be a failure of the drug. So patients will not, motor symptoms will not improve. And gastroparesis also has various treatments. Of course, we get the gastroenterologist to help us with this regard to these treatments. Small intestine also is slow. So you can have bacterial overgrowth. These are colonized bacteria in the colon coming backwards to the small intestine, not uncommon. And this can result in malabsorption, may explain loss of weight in certain patients, and impaired GI motility favors its occurrence. Another problem with Parkinson patients is postprandial hypotension. When you're taking the meal, all of a sudden you feel dizzy. When you get up and try to walk, you fall. So postprandial hypotension also is common, and these are usually with carbohydrate diet. So, and the starts usually 15 minutes from the meal and may last up to 3 hours. How you counteract is to reduce the amount of meal you take, reduce carbohydrate load, and also sometimes we advise them to have a nap, to lie down to count during the period that the blood pressure is low. Constipation is a common symptom in Parkinson's disease, starts before the starting of the motor syndrome.
Excuse me, Gamini, you have 4 more minutes.
Okay. I don't think I will be able to finish all of the things, but I will talk about constipation. Up to 80% will have it, and this is due to increased colonic transit time, and this is due to Lewy body deposition, deposition in the mesenteric plexus. So treatment is you increase the fluid and then dietary fibers, stool softness, and so you take various measures to counteract this. This has to be picked up by asking. Sometimes you do not complain. Patients think these symptoms are not because of Parkinson's disease, so they do not complain. It's a doctor's duty to find out all these symptoms and then reduce the symptom load and relieve them from the symptoms. So in fact, I will rush through and then go to the summary slide. I don't think I will have time to go through all of them. So Parkinson's disease is a multi-system disorder. It's not just a movement disorder. And non-motor symptoms are diverse, multiple, and common at all stages of the disease. And more evident, this is more evident as the disease progresses. And non-motor symptoms are underreported, under-recognized by the family and the doctors, and adds more to suffering than from the motor symptoms. And many patients have average of 9 symptoms. Non-motor symptoms caused not only by disease, but also by the medications used to treat Parkinson's disease. And this is something that can be, there is something that can be done for each non-motor symptom to help these patients out. Thank you very much.
Thank you, Gamini. If there are any questions, I think we could entertain maybe 1 or 2.
Hello, can you hear me?
Gamini, did you hear the question? I'm sorry.
No, I did not hear. Can you repeat the
sorry,
question?
Yeah. The question is, what are your thoughts on RTN and cognition in Parkinson's disease? We see a lot of clinicians using the drug, especially to control tremor.
RTN is a good drug to control the tremor. Kishara, you can hear me now?
Yes.
RTN is a good drug to control the tremor, that's true. But in elderly, with Parkinson's disease, RTN, when you introduce, sometimes they can cause confusion. So it's not a preferred drug in elderly. So especially with Parkinson's, you have to be very careful in elderly ones, especially with Parkinson's disease dementia. You might push them to confusion, especially if the patient had dementia, a non-patient with dementia or Parkinson's disease MCI. Best to avoid it. Especially if you develop any confusion or delirium, that is the first drug to come off, actually.
Thank you. I think we've got time. We've run out of time. Thank you very much for joining us online, Dr. Gamini Pathirana.
Thank you very much, and sorry for not being able to be there physically, Sharon.
Yeah, that's all right. And we are very grateful for your presence here today. Right. Thank you very much.
Thank you.